years. Sorry, over the years. And so I would hope that you will take away something from today's meeting. I very much look forward to the contribution that will come from the audience as well as we move forward. My phone was ringing. As we move forward, and I look forward to your participation in this conference. Thank you all very much indeed. So can I hand back to Dennis or Frank, who's going to lead on it? Frank.
Thank you very much, Lord Ribeiro. Well, I'd like to thank all the participants who actually I'm fortunate enough to have met and know personally along the way, and to introduce the audience to the participants this afternoon. This is our second annual symposium. Last year, we were fortunate to have some experts in various aspects of surgical safety, and we are this year as well. And it's a broad range of topics. I'll introduce each one as we come to the speaker. Our first speaker this afternoon is going to be John Machin. And now John is currently a fellow at the Nuffield Orthopaedic Centre in Oxford. So he's post-CCT. No doubt he's sitting, waiting to choose the orthopaedic job that he'd like along the way. But he's been a clinical lead for litigation at GIRFT, getting it right first time. And he's worked very closely with Professor Tim Briggs at NHS England and Improvement. John has personally looked at aspects of correspondence and documentation of surgical procedures to reduce litigation. And he's drawn up which he will tell you about in his talks, processes and communication documents for many procedures in surgery, off his own bat, but with the support of the Royal Colleges and GIRFT. He's an Oxford graduate, he's a Royal College of Surgeons Fellow, and he's done an international fellowship in lower limb reconstruction at the Oncology Unit in British Columbia in Vancouver. So I think rather than talk any more about him, John, if I can hand over to you to bring up your slides with Dennis's help and let you go. Thank you.
Well, thank you for the kind introduction and for the invitation to come and present to you today the work that we've done at GIRFT, looking at learning from litigation claims. So as has already been mentioned, the work that I present today, I've done with Professor Tim Briggs over the last 10 years as we've been on the journey looking at litigation through the GIRFT programme. So you all will probably be very familiar with GIRFT. This presentation has got a lot easier over the years. So we're now in over 40 clinical specialties. What is special about GIRFT is that we're led by frontline clinicians who are experts in their area who can review practice at individual trusts. But it's all about coming to trusts and working on a peer-to-peer engagement level to help identify changes that can improve patient care, as well as delivering efficiency. And once you improve patient safety and efficiency, we've also found that those changes can lead to delivering savings as well, as is shown on this slide. But underneath everything that we do at GIRFT is looking at tackling unwarranted variation to improve the quality of patient care. And as I said, this releases the savings as well in due course. I just included a slide about the elective recovery programme and the high volume, low complexity work. This is currently the piece of work that GIRFT is leading on, and how you might most likely come into contact with GIRFT at the moment. So during the pandemic, we set up a number of specialty gateways, setting out what top decile performance was for high volume, low complexity procedures. Some of the obviously most common procedures that we carry out as surgeons. And these gateways have been set up in conjunction with best practice pathways, which have been developed through large scale clinician involvement and of course the Royal Colleges to develop these shared pathways, so that for the first time in across large regions such as London, we can all work from the same hymn sheet across the same pathways as surgeons. And this is being tracked and monitored through the model health system. So I would encourage anyone that doesn't have access already to go to the model health system, where you can track the performance of your trust. But onto litigation as the subject that I'm speaking about today. So what's the problem with litigation? The current provisions for liabilities of known claims is 83 billion, which is absolutely staggering. This is second only to nuclear decommissioning in terms of what's on the Treasury's books. And last year, this represented a cost of £2.2 billion to trusts in England. This is over an 85% increase since 2014-15. So this is a growing problem and now represents just over 1.5% of the NHS budget in England. And last year, the incidents that occurred have been estimated to have a cost of harm of around 7.9 billion. So again, a growing problem. And what that represents, more to come to a patient safety point, is that there's been reported and NHS Resolution has been notified of over 12,000 claims last year. So why is GIRFT as a clinical quality and improvement programme interested in litigation? So when we started the programme, there was no national programme for learning from clinical negligence claims to improve patient safety. And there was no parity with incident learning. Obviously, as clinicians, we hear a lot about incident learning, which is of course very important. But we felt litigation is another area which could considerably contribute to learning and improvement of patient safety. There's no best practice guidance in claims handling or claims learning, no measure for hospital performances or incentives for best practice, and most importantly, no guidance for frontline clinicians. So when the first visits were carried out to trusts by Professor Tim Briggs, when he visited every orthopaedic department in England, we calculated that the estimated cost per orthopaedic spell of litigation was as high as £153, when in fact that was the average. So that was very surprising to us, because that is a large amount of money which we felt could be better spent on patient care, and especially now, obviously dealing with the backlog. So at that point, we included litigation in our long-term plans for the programme. And this is a graph or a slide just to show that orthopedics is not alone with problems in terms of litigation costs. We can see that most specialties, specifically surgical specialties, are higher risk and therefore have a large cost on the books in terms of their claims. And these charts, each bar shows a trust, and we can see there's a large variation in the amount trusts are paying per activity or per admission in terms of litigation. So there's a lot to be done in terms of improving learning and improving patient care. So does this strategy of sharing litigation claims and clinical negligence claims with clinicians and working to learn from claims work? Well, we think it does. We've shown this in trauma and orthopedics, where during the course of this program, it's dropped from the number 1 to the number 2 most litigated specialty. We've also seen a drop in the share of costs from 10% down to 5%. And orthopedics really has bucked the trend in, whilst in the background, there's been a general increase in the cost of claims. It's estimated that this has saved up to £140 million by the change in trajectory of orthopedics. And we have seen some of that saving passed on to individual trusts, as you can see there. We're also beginning to see improvements in terms of claims volume in other surgical specialties and related specialties such as breast surgery and obstetrics, and we continue to work across all specialties. So what is our strategy and our approach to this? So we think there are 3 key factors that contribute to the variation in litigation costs and litigation numbers. These are firstly clinical performance of the department involved, and obviously that's dealt through our standard work streams with our clinical leads in each specialty, looking at the performance and improving the patient safety and patient care received at each unit level. Then we have factors 2 and 3, which are performance of the legal or claims handling at a trust level, and how well, the trust governance structure is designed to learn from claims so that these can be shared with frontline clinicians. And really, factors 2 and 3 are what our litigation workstream looks at. So how are we addressing that? We've discussed the factors. So we produce on an annual basis a litigation data pack, which has a 5-point action plan. So this is due to be refreshed in the next month. We send out a litigation pack to every trust in England. And in this pack, we have a metric, which is the estimated cost of the litigation claims from the last 5 years, which have been notified to NHS Resolution over the activity that's been performed by that unit. So that allows us to benchmark different hospitals against each other. And we then divide these into quartiles. So we can identify or allow trusts to identify which specialties are performing better or worse and where they might want to target their learning. And this is an example of our updated spinal surgery graphs, where you can see that there are significant costs in litigation still, with over £11,000 there at the worst performing trust in terms of the cost of claims that they have received over the last 5 years when their activity is compared to other units. And we're developing further metrics. This is a funnel graph, which is based on contributions, so that we can give more accurate representation of the costs that trusts are paying, rather than just relying on estimated costs. But that's one for the future. At the back of the data packs, we have an appendix where we list the claims references so that trusts can identify the claims which have been referred to in the metrics that have been calculated. So in the 5-point plan, we ask first of all that each department, each surgical department should assess their benchmark position compared to other departments nationally, and then look at the individual claims and confirm whether they've been coded to the right specialty, because the data is only as good as the data which has been supplied to NHS Resolution by trusts. So there are instances where the data may have been coded to an incorrect specialty, and that needs to be improved. So this process allows us not only to review claims, but also to improve the data going into the system. Thirdly, we then ask that there is a detailed review of claims. So each individual claim is look at the witness statements that were submitted, the panel firm reports and the patient records, because these are the important learning documents which often we're not aware of as clinicians, which can explain why certain outcomes occurred, but also lead us to patient safety learning points. And then fourthly, we ask for the triangulation of claims with learning from themes from complaints, inquests and patient safety incidents. Where a claim has already been investigated as a patient safety incident, it may be that these things have been learnt and changes have been made. But where a claim has not been investigated, we would ask that process to be carried out. And this was a recommendation we put together in conjunction with Sir Robert Francis. And ultimately, when all this learning has been carried out, it's important that it's not just kept on file, but it's actually shared with frontline clinicians through departmental clinical governance meetings and multidisciplinary meetings where appropriate. And so finally, the 5th part of the plan is that as GIRFT, we are supporting trusts that are outside the top quartile performance through our clinical leads and through regional teams at NHS England, but also we provide national guidance. And this is an example of our documentation guidance that was mentioned earlier. So this is documentation guidance for carrying out hip and knee arthroplasty. This was carried out in conjunction with the British Orthopaedic Association, the British Hip Society, and BASC, representing knee surgeons. And the purpose of this documentation guidance is, I realise as somebody that's recently completed training, as trainees, we're not taught what we need to document in terms of each operation. We're not aware of what somebody coming behind us to investigate a claim or an incident will be looking for. And so this guidance is to clearly define what needs to be recorded and the whole purpose is that good clinical practice that then can be defended, but also incidents or claims can be quickly investigated and resolved, which will both improve patient experience, but will also improve our experience as clinicians and surgeons. So we're continuing to produce these in other specialties as well, which I'll mention later. So what else have we produced? We've produced our Learning from a Litigation Claims Best Practice Guide in recognition from the feedback we've received from GIRFT visits. We know that many clinicians and managers are unaware of claims against their departments or unable to learn from them. Claims learning has been missed from these departmental meetings and clinical governance structures. And across the system, the claims learning has not had the attention it requires in terms of providing potential improvements in patient safety and, as I've already said, the reduction in costs that can be achieved from carrying out these improvements. We noticed that there's no structure for learning from clinical negligence claims, and we wanted to provide this for trusts so that trust legal departments can be supported by both clinicians and managers. So how was this created? Well, we had feedback through our GIRFT specialty work streams, our litigation data packs that I've already mentioned. We carried out some specific visits so we could study what was going on in high and low performing trusts in key surgical specialties, and we took legal feedback from NHS Resolution and the panel firms. This is some of the examples of the contents. I won't go through the whole best practice guide, but I wanted to highlight here that it's important the information that NHS Resolution receives from trusts because the clinical details that they receive inform our learning at a national level. So we've produced here a set of clinical details and claim details that we would like trusts to submit so that clinicians are aware of these. And we note that sometimes it might be quite time consuming to carry out this work. And as a result, we recommended that it may be that job planning time is required by a clinician in a department to provide this service. We also wanted to highlight that there are learning networks and support across the trust, either from complaints, the legal department providing resources from inquest, patient safety departments providing incident reports, and of course all of this is enriched by clinical teams. And we also wanted to make trusts aware that there is support from NHS Resolution in terms of learning, and also that panel firm for each trust is able to support and provide additional information. So in summary from this, what we want is learning from clinical negligence claims involving both the legal department so that complaints, patient safety are brought together along with clinical teams to learn from claims, to get that combined learning so that we triangulate the themes from claims, complaints, incidents and inquests. We want to work in partnership with patients, families and carers and involve them with patient safety investigations to ensure openness and candour, and signpost to support and commit to shared learning. Clinical departments' claims should be discussed on a regular basis, as I've already said, at a governance, as part of the governance structure. We recommend that in those busier departments, it might be at a quarterly basis to really make sure that learning is brought across. These are examples of some of the good practice that's highlighted in the guide from various trusts across the country. And we also suggest a number of monitoring points that can be carried out in order that a trust can follow the improvements they make in terms of claims learning. So in summary, this guide has really 5 key recommendations. We recommend appointing a dedicated clinical staff member to assist in the trust legal team to highlight patient safety issues with sessions incorporated in their job plan to facilitate that. We recommend regular discussions of claims with clinicians in forums such as clinical governance and MDT meetings to introduce focused improvement. We want to make sure that clinicians are more aware of the claims process, ensuring that legal teams are more visible to clinical staff at all times so that there is that conversation and shared learning. We want to ensure clinical staff are aware of when a claim has been initiated, because often there are problems when a clinician only finds out later down the line and feels disengaged with the process. So we want to make sure that clinical staff are fully supported through this. And we want to recommend working in partnership with patients and their families and carers to involve them in investigations and to ensure openness. So just to come back to the objectives that I set out at the beginning, how are we doing? So we've created a national programme for learning from clinical negligence claims in collaboration with NHS Resolution. We also contribute to the National Patient Safety Strategy to help give parity with instant learning, but also to share that important crossover of learning between those key national data sets. We have provided a best practice guide for claims learning, which was produced last year and is available through our best practice library on the GIRFT website. We're measuring hospital performance to incentivize improvements in learning from claims through our litigation data packs, and we're providing guidance to frontline clinicians. We've already produced the hip and knee arthroplasty guidance. We will be shortly producing our general surgery guidance, which will include laparotomy and bowel resection, lap appendicectomy, lap chole, open and laparoscopic inguinal hernia repair, and thyroidectomy. And we hope surgeons will benefit from this advice and guidance. And we plan to carry this out through other high volume operations in order that this information is shared, but also the case vignettes which underpin this guidance can be shared with clinicians to really give the relevance of the guidance that's provided. We plan to share these case vignettes with CORESS to allow wider dissemination of the learning as part of our shared aim to improve patient safety. Thank you for listening. I'm happy to take any questions.
John, thank you very much indeed. That was a tour de force, a very erudite and measured lecture, and that's opened up a lot of questions. A couple of housekeeping things, if I may, if everybody could make sure that during the talks their microphones are switched off. That way we won't get the feedback. So thank you very much for that. And if people want to ask questions, could they do that through the chat function? And we'll moderate and take a couple of questions for each speaker as we go. And John, you have had a couple of questions pop up during your talk. The first question is whether the data is open to the public to see the specialty litigation benchmarking. Is it looked at by groups in big trusts or by site?
So the litigation data packs are not on the model hospital, which is available to anyone with an NHS email address. Instead, we send out the litigation data packs to trusts individually because the information in them is confidential to that individual trust. So trusts are able to identify themselves, but they aren't able to identify any other trusts on the graphs. In terms of the public, so these are not publicly available. We basically ask trusts, we send it to medical directors or GIRFT champions and CEOs, and NHS resolutions send this on to trust legal departments so that together we can reach as many people as possible. And we ask individuals that we share the reports with to cascade it on to clinical directors. We're unable to share it directly with all clinical directors given the nature of the change in personnel on that level. But the idea is to share it with as many clinicians as possible at a trust level so that as many people are aware of the claims and are able to support the legal department in learning from them.
Thank you, John. That's very good answer again. There are several questions. We won't be able to go through all of them, but if I may just take a couple more. One of the contributors to this meeting asked whether GIRFT's taking this approach to reducing litigation with independent hospitals, of course, who have their fair share of litigation as well as the NHS, and particularly in terms of high volume, low complexity work, which would often be funded by the NHS. The NHS indemnify those claims, but obviously they're not indemnified in the private sector. So have you got a comment on that?
So we can receive data, but only on as is suggested, on NHS work carried out in the independent sector. We're unable to look across the whole independent sector because that's not covered by NHS resolution. We haven't looked specifically at independent sector litigation currently because we're focused on the NHS primarily. But there is a crossover. Some of those claims, if they come through trust activity, will actually be recorded under the trust if the trust has taken them to the independent sector, for example. So some of it will already be covered in the work that we've carried out. On our larger review of claims, not the individual review of trusts, we look at all claims across whatever sector they come from that are covered by NHS resolution. So we do get some shared learning across there. But GIRFT has only recently expanded into the independent sector over the last few years. So the potential problems with looking at it in the same way is the volume isn't always as high. So it makes the interpretation more difficult, so the metrics fall down. But it is something that we're looking at in the future, and especially, as you mentioned, with the rollout of high volume, low complexity. So it's something that we want to look at as we assure standards across both clinical practice, but also the back end, such as claims learning.
Okay, thank you very much. There was a second question from Annie Hunninger, which actually I won't take because I think it was partially answered by a slide which came after her question, but maybe she could have a chat afterwards about that. And I will ask you a very quick final question. Rohit Janeja asks whether the projected savings that you showed on your first slide for 17-18 have actually been demonstrated through to 2021. Is there evidence of those savings?
So the savings that I showed was a calculation across all those years. So because the saving, the 145 million, was across all those years that were shown on that graph. So that's these are estimated savings when we plot the trajectory of claims across the NHS as the whole, with the assumption that orthopedics continued to match the NHS as a whole. So it's an estimated cost saving. With those, though, we have had specific information that was shown at the bottom of that slide from the Royal National Orthopaedic Hospital and also St George's, where their reduction in orthopaedic litigation has led to a reduction in their contribution for litigation from NHS resolution. So that is obviously very clear and easy to define at a trust level. And that slide with the funnel plot where I showed which was a new metric that we're developing with the government actuaries department, is going to be based on actual payments made by trust to NHS resolution on a yearly basis. And therefore it will be much more robust in terms of reflecting the costs actually paid, rather than relying on estimation. And you may say, why do we ever use estimation? Well, the problem is claims happen over a long period of time, and we always are balancing showing trust the most recent claims versus showing the claims that have settled. So there's always a balance, and we need to look through those two different lenses when we're looking at learning and we're tracking what has occurred in terms of claims improvement or claims learning.
Thank you very much indeed, John. A very good lecture. We're very grateful to your contribution and indeed for the links that hopefully we'll be developing with you and GIRFT along the way. So I'd like to thank you on behalf of everybody. We're now going to go to the second speaker in this meeting. And the second speaker, I would point out that CORESS survives with support from various organisations. That the MDU help us, AXA Health have helped us, the Hospital Saturday Fund, and WPA. So we're grateful to AXA for not only supporting us in our activities, but for supporting us with a speaker today. Pallavi Bradshaw studied medicine at the University of Cambridge. She was originally an ophthalmologist along the way. She worked extensively with the Medical Protection Society, and she's pursued I think she would forgive me for saying, a portfolio career looking at medical safety in a number of organisations. She's currently the Deputy Chief Medical Officer with Medico Legal at AXA Health, and she's written an presented extensively on patient safety issues. She's going to talk to us about preventing avoidable harms, the insurer's role. Pallavi, thank you very much indeed.
Thanks, Frank. That was great. I was on mute, schoolgirl error. So yes, thanks very much for inviting me to speak today. I was really interested in hearing, obviously with my background for many years at MPS, and interested to hear about independent sector claims. So I did a lot of work here, the last part that I was working at MPS, looking at how we learnt from litigation and reduced medico-legal. So there is some of that work going on in the independent sector, but certainly not as much as probably should be. And as you pointed out, the independent sector is not immune from litigation and from avoidable harms. And I think certainly, although a lot of focus happens in the NHS, we as a sector need to support each other and have build that open and transparent culture that's required. And I'm sure people will know, of course, of Patterson, and that certainly led to scrutiny and a light being shone on particularly perhaps gaps in the governance in the independent sector that obviously we're all working to improve and to prevent. And as insurers, we've had to hold a mirror up to ourselves and to see what role we play. Obviously, we don't have an official governance role, but we certainly can use our influence on providers and specialists. And so I'm going to talk about what we are doing at AXA Health, which some people may be surprised by what we are doing. So just a bit of background for those who aren't familiar with AXA Health. We're a private medical insurer. We support the health and well-being of 2.8 million customers and patients within the UK, and we form part of the wider AXA group. And we essentially fund the care for members that are provided by third-party clinical providers. And we source those parties to help us in our pathways, things like mental health, cancer, MSK. And during the pandemic in particular, we partnered with Dr. Care Anywhere to provide remote GP services, and that's been ongoing. So we obviously have an interest in the quality and safety of clinical care that is being offered to our members, but also where we are in partnership, we have a greater role, obviously. So what do we do in order to satisfy ourselves about the safety and efficacy of the care that's being provided? Well, we obviously look at data, evidence-based medicine, look at internal information, external. We're very reliant on external information. I'll talk a bit more about that. And also we undertake clinical risk assessments on the pathways and the propositions that we are developing to ensure that due diligence is done and that the providers are meeting a particular standard for quality to ensure that the patients are receiving care that is of a good standard. And when we are funding care, we do have a patient safety tool to look at funding. Obviously, as much as there is nice guidelines, it can't cover every eventuality. So there will be situations where there'll be novel care, there'll be novel treatments where we're being asked to fund. And we need to be prudent, not only financially, but in order to make sure that it is safe for our members. And a lot of members may assume in the private healthcare, well, I've got insurance, so just pay it, that's what I want. But we obviously have a duty to our members to make sure that what they are being provided is safe and effective. It's not just about the funding. So why is patient safety our priority? AXA is a big global entity. People will think, oh, we're just interested in profit, but that's absolutely not the case. And the vision and the mission of the CMO team is very much around patient safety. That is our priority. We must make sure that the members who ultimately are paying our wages have safe and effective care and that they get better when they seek that care. It's clearly a moral imperative, not only to safeguard the interests of our members, but of patients generally as a whole, across the whole of the independent sector, but also across the NHS. And I'll talk about some of the work we're trying to do in order to join that up. We have regulatory obligations as AXA Health to ensure that our customers are protected. And myself and my colleagues in the CMO team, as individual clinicians, we are also registered medical practitioners. So we have our own individual obligations to ensure patient safety. As I mentioned, post-Patterson, we're all very acutely aware of what we need to do to ensure that such a heinous scandal doesn't happen again. And of course, we also know it makes sense that if we have good, high quality care, that does lead to financial efficiencies, and value-based healthcare is something that we obviously strive to, and to try and incentivize good quality outcomes for providers and for our patients. And by leading on patient safety, and we hope that AXA will, we can hopefully be a market that will be a market differentiator for us, so that our patients and members know that when they go and see a clinician or a provider that is recognised by AXA, that they will get good quality, safe and effective care. As I said, we're there to assure the safety and quality, and we do that by various things. We also are very reliant on the external governance framework. So that's why we need to make sure that that is fit for purpose and that's working. We look at various things throughout AXA. We rely obviously on CQC and GMC for that sort of formal regulation, but we also do ask that our providers provide us with certain information that will help us know about complaints, the never events, significant events, and we try and work with them in order to ensure that we have that assurance. I know that a lot of people may be skeptical as to why insurers want this information. I'd like to reassure them it is purely around patient safety. It's not something punitive. We're here to try and work in partnership to improve patient safety. And we do a lot of stakeholder engagement. So we discuss regularly with the CMOs, with medical directors of the private providers. Personally, I have a strong responsible officer network that I can discuss concerns that might arise from time to time about independent practitioners. As you've said, Frank, we are very proud to be sponsoring and partnering with CORESS, who you've already helped us with various things about how we take some of the learnings from the significant events that we're aware of and spread that across the sector. We obviously lobby Parliament, as you would imagine. And something that we are hoping to lead on is a patient safety forum that we wish to launch in later this year, where we will be taking the medics and the governance leads of the private sector and taking anonymised cases where we can learn, where there is cross-sector learning. And I'm also looking at working with NHS resolution, because clearly there's no point in us learning from mistakes within the independent sector if it's going to help patients in the NHS and vice versa. So this really is a collaborative space where we're hoping that we can set any commercial interests aside and really take a step forward and help support and foster that open and learning culture, and really sort of walk the walk and talk the talk. So looking at some of the data that we have access to, I think a lot of people are surprised that actually we don't have access to loads of data about people. Really, the data that we generally hold and ask for is related to us being able to fund care. So it is very limited what we have. If there are incidents that arise, we may ask for more information, but that requires us to get patient consent, which we may not always get. We're really keen on FIN to get the data that's required under the CMA order. So that will obviously help benchmark. So we have a lot of that in the NHS through GIRFT. Unfortunately, we don't have that, and we're slightly frustrated at the moment about the pace that's moving in, but certainly we feel that providers and specialists really do need to engage with that, because it's in the interests of patients to make informed decisions. We're also very keen on getting PROMs and PREMs standardised across the sector, so that we can then really compare and see what matters to patients and what really makes them decide on whether they do or don't have treatment. And we also obviously use population health data so that we can plan for the future and also focus on preventative measures so that our members then don't end up needing to go into hospital, for example. And I mentioned that we meet with governance teams generally on a quarterly basis, and we look at significant events and complaints. We try to see if there are themes at particular groups or hospitals, or if they're specialists with particular areas that we want to delve into further. And we have that constructive dialogue in order to try and improve and to prevent things from happening, because clearly we know that adverse events will happen in healthcare, but it's how we learn from them and how we deal with them that clearly is important and will prevent future harms. So from the point of view, what I do in particular, I look at specialist governance. So we obviously contract with tens of thousands of doctors, other healthcare professionals, physios, occupational therapists, all of those people. And so we need to be clear as to make sure that they are fit to be treating our members. So we rely on the GMC, the HCPC, but there's also insight and data that we can look at that we have. So looking at outlier data, what I mean by that is, are particular specialists charging us for unusual treatments for their speciality, or are they combining things that we wouldn't ordinarily see? We also use pseudo markers, so returns to theatres, hematoma rates, prolonged stays in hospital, and we will look into that. And also we see often billing, people who do bill higher than normal, that can sometimes make us suspicious of a clinical anomaly, so we will look further into that. We also have a fitness to practice process, so that if concerns do get flagged within AXA Health, we do have a way of scrutinising and being fair and transparent about how we deal with those. And they may need to be escalated, you know, to responsible officers, or in worst case scenario to other authorities such as the GMC. One of the areas, though, that we do have difficulty is in relation to sharing some of that information. If it reaches the fitness to practice threshold, that becomes easy. We can pass that on to the responsible officers. But it's where they're slightly lower level, being able to share that information where we have contracts that are with the consultants themselves and with providers. We do have some GDPR issues that we are trying to address through the contracts that we have. And we're certainly talking to various bodies such as IHPN in the GMC as to how we might be able to deal with those. And I discussed already that we do have regular dialogue with the governance teams within the private hospitals. And it's interesting, the ones that tend to be more open to sharing, we tend to have less concern about, which I'm sure people will realise why. And those who are less willing to share, sometimes we do have concern, but we're building those relationships and the trust with them, and hopefully we can take that more going forward. And with this patient safety forum, we're hoping we can have that constructive and supportive dialogue. So just a couple of case studies to show and demonstrate some of the work that we have been doing. So we had a provider who had a CQC rating of require improvement. And that in itself obviously has some alarm bells for us. You know, is this an institution or a provider that we want to be working with? In this instance, they were looking after vulnerable patients. So clearly we didn't want to pull them from a network when there would be continuity of care and disruption. So we instigated the standard operating process, which allowed us to risk assess what was happening. We sought assurances from the provider, and we considered whether we needed to undertake a full review ourselves or to audit. And what we decided, having spoken to the governance teams, was that actually we were happy to continue with them, seeing the patients that they already had on their books, as it were, but not to send any new patients until we were clear about the safety aspects. And so our clinical quality and governance team worked constructively with theirs. They provided an action plan, they gave us a time frame for their implementation of when they were going to instigate. And that just allowed us to have that assurance that we needed. So it didn't mean that we had to wait for a re-inspection with the CQC that obviously at the time with their backlog could take a long time to happen. And it meant that we were happy that our patients were going to be safe, and that we could continue with them on our network. And I spoke at the start about this patient safety tool, about the way that we decide on treatments. So we have a green, amber and red system. So if somebody is requesting a treatment that may be novel, that may be new, there may not be nice guidelines out there, it's not a flat no, but what we will do is our medical policy team will undertake a review of any relevant data and evidence, and we look at, is there high quality, high impact evidence about safety and efficacy, even if there isn't nice guidelines, for example. And where we feel that actually there may be, and it's in the benefit of the patient, and we've had medical reports and MDTs have been carried out, then we may well fund that treatment or at least offer a financial contribution. Where there isn't that data, so often we will get asked, to fund, various things because a specialist is undertaking a trial or they are a world expert, unless we are satisfied that there is safety, particularly given that a lot of these patients may be vulnerable, they may be desperate. I think it is important that we have that safeguard in place, and anybody interested can have a look on our provider website as to how we do make those decisions. And I guess this case just highlights how we have picked up some areas where, we've had concern about patient safety, where we had an orthopedic surgeon who was undertaking bespoke hips. We noticed through our fraud, waste and abuse investigations, they were also an outlier for costs. They were using hips with an ODEP rating, a prosthesis of 3, as opposed to the standard, which is 10. So this clearly was something that we were concerned about. And so we queried it with a provider and with a specialist, and it became apparent that there wasn't any clear documentation around informed consent. So members weren't necessarily being told about the outcomes and the safety and the quality of the prosthesis. And we weren't getting very good engagement. In fact, the specialist didn't really talk to us about it. Given that, and given the professional obligations around the lack of informed consent, the fact that safety issues were not being addressed, and the fact that there was a failure to engage, this was a case that we thought did meet the threshold around fitness to practice. So we engaged the responsible officer and we then de-recognised. Now, in the past, we may have decided that actually we would just de-recognise the specialists, they couldn't see AXA members. But as I say, we have that moral duty to ensure patients are safe everywhere. So that's why we made that notification to the RO so that they could then triangulate any other information that there may be there. And I'm just on to the final case. So not infrequently, we get called up on our fraud tip line from whistleblowers. They're often colleagues of consultants who either have tried to raise their concerns locally and hit a brick wall, or they're afraid to raise concerns. And that's really interesting. Even in the private sector, people are worried about repercussions of raising concern. And that's where I think CORESS and other bodies and ourselves can really try and encourage and support that open culture so that people don't fear raising issues. And in this situation, they were worried that this particular specialist was miscoding, opcoding, so using the wrong codes for treatment, had lots of patients on their list. It didn't seem viable that they could do as many patients as they said they were doing. And we did look into this, and we saw that actually this consultant was carrying out a scope of practice that was different in the private sector to the NHS, which is clearly worrying. Hopefully that shouldn't happen now with whole practice appraisals. And we also noted a very high conversion rate of surgery. So we undertook a medico-legal review of the cases that we had, and it was clear that actually a lot of unnecessary treatments were happening, and there was a high proportion of poor outcomes, and the experts' opinions were rather unsupportive. We didn't really get very far with trying to get more information from the specialist. We weren't getting records, we weren't getting scans, and the management at the time as well didn't seem to want to engage with us on trying to get to the bottom of it. So given the safeguarding concerns in that instance, we felt that there were no other options but to involve the GMC, the CQC and the police. And actually this specialist is facing a criminal trial later on this year. So hopefully I've demonstrated that it's not just about the money, that we are here looking out for our patients, and that we really do have a focus on patient safety, and we want to work with the sector, work across the private sector and the NHS to achieve that.
Pallavi, thank you very much indeed. And that tailors in very well to John's talk. It seems that there's a lot of overlap. So you've actually filled in some of the aspects, like two jigsaw pieces fitting together, of things that John wasn't able to cover because some of his work is NHS. And it does look like John's documentation may be particularly relevant to you along the way.
Absolutely.
Annabelle Bentley, who you work closely with, is talking about culture change and speaking up as the key. So I don't know if you'd like to comment on that.
Absolutely. I think, as I say, We hear time and time again in the NHS about various scandals, people too afraid to speak up. As I said, it's unusual. I didn't think in the private sector it would be quite so much of an issue, but it clearly is. I think as well with commercial interests, sometimes there can be this reticence to share information. We had a particular case, Frank, that I know we've discussed with you, where the hospital group in question did a great job in instigating change within their own private hospital group, but getting that information out to the wider sector, there has been some reluctance, and it's trying to understand why that is, setting aside some of those commercial interests, but also seeing that we do get those whistleblower calls where people say, I'm genuinely worried about my job, I don't want to rock the boat, or they have in fact had problems. I only this week was talking to an ophthalmologist who raised a concern about a colleague in the private sector, and he himself then ended up getting investigated rather than it being the person that he'd raised the concern about. So there still very much is that culture of fear, and until we crack that nut, we unfortunately are always going to get those issues. And in my background at MPS, we were constantly talking about speaking up for safety and trying to encourage, but the reality is out there that a lot of clinicians are scared, which is why reporting anonymously, such as through CORESS, really is at the moment key until we can get to that place where people feel safe to raise concerns openly.
Well, thank you very much indeed. I know there's quite a large audience, and it's impossible to know everybody's backgrounds, but the thought of police and GMC investigation scares everybody. And I know Dennis Wilkins and I would, CORESS was founded around the philosophy of there, but for the grace of God, go I, and that's why we learn from CORESS. And I would emphasize that as a reporting structure, CORESS is strictly confidential, but which is why it's so good to hear other aspects of procedures along the way. So Pallavi, I'd like to thank you very much indeed for sharing those insights with us, and we'll proceed with the meeting if we may. Our next speaker, I heard speaking, in fact, at the first meeting I went to after the pandemic. I think the first, we'd all been tied up at home, and then suddenly we went to the Excel Centre and there were millions of people there. And at that I heard Annie Hunninger, who is a consultant anaesthetist working at the Royal London Hospital, speak on surgical safety. And it was immediately apparent that we should get her to speak to CORESS at some stage. Just to tell you a little bit about her, Annie sits on the steering group of the Royal College of Anaesthetists as the lead for National Safety Standards for Invasive Procedures 2. I think CORESS was involved in 1, so I'm delighted to be hearing about what's involved in NATSIPS 2. All of these acronyms run off the tongue in a slightly difficult way, but Annie is co-authoring NATSIPS 2. She's got a whole background in safety, and I will just highlight 1 or 2 things. She and the NATSIPS team were awarded the Barts Health Hero Award for safety. She's developed a variety of courses. The thing that fascinated me was that she was awarded the Humphrey Davy Award of the Royal College of Anaesthetists, which is a very prestigious award for a return to work course for anaesthetists, which was appropriately entitled Gas Again. So Annie, we're looking forward to hearing your talk, and thank you very much for coming to talk to us this afternoon.
Thank you so much for that lovely introduction, and what fantastic speakers today. It's amazing to be here, and great work that you've done with CORESS and continue to do. Yeah, as you said, I'm here to talk to you about the National Standards for Invasive Procedures, the National Safety Standards for Invasive Procedures 2, and I'm a consultant in anaesthesia at the Royal London. I know many of you on the call will be surgeons. I'm sure you'll all remember the time when we didn't even have a checklist. And 12 years ago, the WHO checklist came and was I think we'd all agree, a great step forward in safety in our operating theatres. NATSIPS 1 then came, which brought, these ideas that have already been mentioned today around systems, around culture, around human factors and teamwork to the fore, to give us a process for safety. And so NATSIPS 2 is the natural kind of evolution, I think. there were some problems with NatSIPS 1, and this was a survey done by NHS England in 2018, which showed us that there was inconsistent and challenging implementation, and there were barriers to embedding this important safety guidance, which links into many of the conversations we've been having today about governance systems, about staff not having protected time, about the sort of lack of opportunities for cross-specialty learning, and particularly, this is from 2018, but now we've got this big focus on productivity and targets. So we have this conflict with safety, maybe not always seeming like the priority, and then a sort of lack of internal expertise. This is what the 2018 survey showed us. And we know that these problems, we know we work in, this is one of our orthopedic theatres, you know, complex operations, big teams, multiple languages spoke, difficult patients, and you can see it would be very easy for things to go wrong within this setting. You know, then over the years, we've looked at never events, and, you know, local to us, Hackney Gazette, surgeons gives patient wrong knee replacement. You know, it's shocking to the public, it's shocking to us, and then lots of cartoons about it in the press. I can't say I'm entirely pleased with my hip replacement. Those of us who've worked in theatres can see how these errors could happen. And really, NatSIPS 1, after NatSIPS 1, one of the issues was that Trust became quite obsessed with never event numbers, which, as you know, you'll all know, are quite a poor measure of safety because they're rare, and very focused on compliance measures, which again really don't tell us about quality and safety. I mean, over the years, I've collected a lot of photos, and I haven't got time to go through them with you now. These were the photos I thought shouldn't necessarily be shared because some of them are old, but just to give you a flavour, you know, if you have a system in your hospital where you write the teeth you're going to extract on the same board as your count board, we can all see where this can go wrong. And this is a system that's setting our team up to fail. So this is for a dental theatre. If we walk past a consent like this, where what right's been crossed out and they've put L instead, then we're asking for trouble. You know, laterality should be written in full, and I certainly wouldn't accept a consent like this. And it goes on, and this is still something that, because as anaesthetists we do signing, we see so often, you know, this is a red flag, and we should have systems in place to stop these kind of things happening. This is a very old photo, and when I speak at some big events, there's usually a gasp from the audience. But, you know, there's something about the discipline in the preparation for surgery and the kind of getting it right first time we've already heard about, that it's not okay for a surgeon to write enjoy under the arrow on patients. I'm sure we'd all agree. And, you know, are we doing an arrow or are we doing a cross? We see huge variation in practice. And so we need to have very clear practice that everyone knows, you know, what good quality, for example, site marking is. You know, this site mark is on a knee, but it says hip. So it's probably for that hip operation to indicate the side. But again, it isn't clear, and we don't really know what it means. And so on. And there's so many photos that I've collected. I don't know what the AS means in this photo. Anterior superior, is it the surgeon's initials? So really understanding what people are doing and why. And then this is an actual recent one that has my initials, which caused a lot of confusion. I certainly didn't write my initials on this patient and the date. I started work on NatSIPS 1 within my trust. Here we are with one of the original authors, Will Harrop-Griffiths, and these are colleagues of mine. And we did a big trust-wide project to really implement NatSIPS in our organisation, following the main three themes that it asks us to do: standardise, harmonise and educate. And based on that, we produced some local standards that were generic to all of our invasive specialties. And so one of the differences with NatSIPS is we were going beyond sort of traditional surgical boundaries into all invasive specialties, so interventional radiology, endoscopy, places like that. But But to write these standards, we used the national guidance, but we also did a deep dive into our incident reporting systems. And so, for example, we'd get all the incidents related to team briefing and build our standards around all of our incidents. And that isn't the way that we usually look at incidents in trust. We're very specialty based, silo based, looking at incidents rather than these sort of deep dives to help us understand the problem across specialties. And I think as anaesthetists, we were in a strong position to understand that because we work with a number of specialties in a number of areas around the hospital. So we can see the variation that might not necessarily be evident within a specialty. And then we created checklists on the back of this when they were dedicated areas. We had specialist checklists, but the point about this is this standardized and harmonization of our checklist meant that in all areas the checklist had the same format, looked the same, and similar questions, which meant that there was this standardization. And some places have lost that and got different checklists in different areas. And so NATSIPS 2 again really promotes this idea to standardize and harmonize across specialties. And we produced a patient information leaflet, which is another theme in NATSIPS 2 around really involving the patient. And it was fantastic to have patient representation on the committee who really helped us build and make sure that the standards were also understood or could be, interpreted by patients in a really positive way. At the time at our trust, we also had a lot of building work going on, and this was a big theme for us around induction and really picking up on the induction standards, that we don't let people onto building sites without an induction, and yet we sometimes let people operate on patients and into theatre without an induction. And part of that induction should be, this is how we operate safely in this organisation. So NATSIPS 2, our chair is Professor Ian Moppet, who's absolutely brilliant. He's from Nottingham, and on the committee there are about 15 of us. This is Susanna Stamford, who's a patient advocate, and I think I just saw her name pop up. She's on the call, and she's done a lot of work. She's a patient who's had an editorial published in Anaesthesia, and Scarlett is an orthopaedic surgeon. So we had a big group of us working on NATSIPS 2. So I just wanted to quickly tell you a bit more about some of the changes, although I've alluded to them already. As you know, it covers a lot of specialties. And so this is a list of the specialties we think it covers, so it goes beyond those traditional surgical boundaries. And what's new about it? Well, now it's owned by CPOC, which is the Centre for Perioperative Care, and it was previously owned by NHS England. So it now represents collaboration across the 4 nations, and that was good on our committee. We had people from all over the UK. We've got less focus on never events, which, as I said, are a poor measure. And so we've got more on quality and teamwork as performance measures. We've got this increased patient involvement with a patient standard, and more focus on proportionality of checks. In these areas, we have professional people who understand risk so that the checks are proportional to the risk within that area, rather than a kind of blanket check. We've aligned it with other recent safety papers and the National Patient Safety Syllabus, and we've really bolstered the organisational standards. I think NATSIPS 1, there was a big focus on what the team were doing and the sequential steps, and sometimes we lost focus on what the organisation should be doing and how the organisation can support the team. We've also built the regulatory, legal and national body expectations to try and integrate NATSIPS 2 into curricula, policy and inspections. So for example, if the CQC comes around, we would hope that they would ask more about NATSIPS than they may have done in the past, and getting local commissioning groups to assess NATSIPS 2 as well, and the performance indicators that we've suggested. So in summary, this is the sort of summary slide of NATSIPS 2. So we've still got the sequential standards, which you'll know from NATSIPS 1, which go beyond the 5 steps to safer surgery to have the NATSIPS 8, as we called them. We've bolstered up the first standard of procedural verification to include consent, which is I think a big issue in surgery across the UK. And I've recently done an audit in my organisation, and we're definitely not, you know, the examples we had around informed decision making, you know, making sure all of that is embodied in people's standards, and then the other standards are the same as before, but a bit more detail, which I'll go into in a minute. And then the organisational standards, we've broken into 3 parts: people, processes, and performance. People, we've got our patients, who are our partners, and then staff. So what are the roles there are in safety within an organisation for them to deliver? What training do our staff have in safety, and our MDT teams in particular? Processes around safety, so how we're documenting. You know, we still see a lot of scheduling errors. I could have showed you a lot of photos of that, just short on time. We talked about induction, but making sure governance is fit for purpose, and there really is this cross-specialty learning and action. And the third P, the data for safety. So less focus on this sort of never event obsession, and looking at other metrics that really indicate to us around performance for safety. I mentioned the standardize, harmonize, educate, but you can see that that SHE can also apply across the organization as well. So standardization of processes, policy, insight, involvement across organizations and specialty, as well as what we're expecting the teams to do in their standardized processes, and then the harmonization, and then the education is so important. I've now trained over 80 MDT teams in safety and systems thinking, but really that has been a labor of love, and there hasn't been ongoing commitment to train our MDT teams, train people in safety across organizations, and that will require, you know, leadership and cultural change. We've also recognized there's this tension, you know, people get checklist fatigue, so there's this tension in having, you know, standardized, harmonized checklists, but the proportional and professional application. And so with that in mind, we've created this divide between minor procedures, which are mainly kind of outpatients or ED procedures, generally where anesthesia isn't involved. And in that setting, we have said that sign-in and time-out can be combined, and that they do one check really well with the patient involved. And major procedures would be anywhere where there's general anesthesia, where there's a bigger team than 2 people, and there we would still expect sign-in and time-out to be done separately. And you can see there's this sort of another way of looking at it, the minor and major differences. And so that's proportional to risk, but also much more rational and useful for teams. As I've said, you know, the safety education processes for the MDT remain a massive issue. I mean, sure a lot of you have looked at the NHS safety syllabus, which is meant to be delivered to every member of staff. And then we have the challenge of, you know, changeover, induction, and the MDT teams really respond well to understanding their safety data and being aware of what's going on, and that safety is, you know, everyone's responsibility, and they're much more engaged with it, and it creating that sort of safety culture. This is one of the teams I've recently trained at St Bart's, the cardiac team. So you've got nurses, ODPs, surgeons, anaesthetists, managers, and we had a really great day looking at some of the themes around, you know, how safety is developing in the UK, around the syllabus, around the NATSIPs. I've also been encouraging the work with, and this is within the NATSIPs too as well. You know, we're sick of people going around with clipboards assessing us. We want to see people to come and work with us and see the issues, go and see work is done, bringing quality improvement to the teams, and seeking to understand the issues and systems engineering, because people will game the system otherwise. And so this proxy diagram I love. There's so many times, you know, we're instructed to do something, we're measured to do something else, but it's this work as done that we really need to understand to get into true quality and safety. And bringing some of this into NATSIPs too is, you know, the GIRFT work, you know, enabling things to go right more, offering learning from excellence, having reliable processes with happy staff, And although checklists are very useful, being less obsessed with compliance. One of the other things we've looked at is rationalizing the kind of paperwork, making it easier for teams, that we don't overburden them. So in our organisation, we had theatre staff counting on a chart, counting on the computer, and counting on the board. And people are so scared of change, or we must document, but it was actually a distraction from doing it well once. The other change in NatSITS 2 is the proportional count concept. Areas like interventional radiology, where the incision is too small to retain a swab, that they've never done a full count in interventional radiology and they never will. So recognizing that the key things they should be counting are the wire and the needle and things that they put through the needle, rather than expecting a full count procedure. So these are some of the areas that we've changed with the national, with the NatSITS 2. We'll all recognise this scene when a swab goes missing, having really clear processes around this within the document. Here it is, they found it, but that everyone understands why this is important, rather than just measuring the never event. The other area that's been contentious, and we still don't really have the answers to, is the green swabs that anaesthetists use for padding, which actually aren't in the count, and I don't want them to be in the count. But as you'll see, they do not have a radio opaque line, but they have been cases for NHS England where they've been mixed up in the count, and when their blood soak's been confused with the count. And so we need to think about, are there other items that we can use for padding, and avoid green swabs is the way the committee's going. The other area we've looked at is around practice around deliberately retained items for packing in a wound or cavity. We've had a number of patients come to harm from packs that were left in and not removed when they were meant to be removed. And so there's a whole new section on this within NatSITS 2. Talking about the measurement and reporting, this is what our data used to look like, 100% in all areas for the WHO checklist. Well, there's 199. But there's nothing to improve here. And you'd look at this and think, okay, great, our teams are perfect. But we all would recognize that this isn't that useful data. So instead, we've been doing more qualitative data. Is the consent correct? Is the marking correct? Was the team brief on time with the lead operator and lead anaesthetist present? Was it a good quality, and so on? And then using this to build improvement. So really encouraging this within NatSITS 2. So in summary, NatSITS 2 has a huge potential to deliver safety improvement, but we are concerned that there will be implementation challenges, like with NatSITS 1. The consultation period has recently just ended, and we're bringing together all the feedback, so it will be published in September, October. There's going to be podcasts and a lot of kind of comms to try and bring people with us. It's still open to comment if anyone would like me to send it to them. I'm going to be working on it this summer, but it's really also building that culturally with our psychological safety of our teams, and understanding work is done is critical. And it's how we do it and sustain it. We need to understand our risks, but also our people. And so we mitigate, improve, and learn from success and excellence. Thank you. If you want to follow me on Twitter, it's Annie Hun, and I'm always tweeting about NatSIPs. Thank you.
Annie, thank you very much. That was a superb talk, down to earth, easy to understand, and actually fits in very well as the third piece of the jigsaw this afternoon. There haven't been any questions to date in the chat function, but I would just make a couple of comments. Firstly, for a while I was really worried because I thought it was my handwriting on one of those consent forms, and it could easily have been along the way. So thank you for flagging that up. All of the surgeons on the call will recognise that search for the missing swab. And I remember a particularly irascible professor of surgery who was detained from leaving theatre because of the swab count. The swab was eventually found in his Wellington boot along the way. So those brought home real life to the rest of us, and we look forward to seeing NatSIPs 2 and I'd encourage everybody who's interested to contact Annie and get hold of a copy of NatSIPS 2. So thank you very much. I know you're working today and you've taken time out of a busy working day. You're the only authentically dressed clinician on the whole talk. So thank you very much, Annie. It's very much appreciated. Okay, that's a pleasure. I'd now like to introduce our last speaker for the afternoon, who's been waiting patiently in the wings. He's a friend and a close colleague. He's a vascular surgeon too. Ashok Handa is an associate professor at Oxford in the Nuffield Department of Surgery. He's a fellow of Catherine's College, and he's largely been responsible for running surgical education at the University of Oxford for the last 10 years. He still runs the surgical aspects of the examinations there now. He's had an interest in patient safety. He's supported the CORESS Advisory Board for some years, and he's also been on the council of the MDU for some years. He's always a good source of advice and a potential source of any relevant literature when we ask him for it. So he's going to talk to us this afternoon about shared decision making and why it's important for patient safety. Ashok, welcome. Thank you.
Thank you. Just checking you can see my slides. Anyone?
Yes, they're visible, Ashok.
Yeah, well, I mean, that's a tough trio to follow, and I thought you might say we haven't got time to carry on, but we do. So this is something in some ways completely different. We've heard already about the size of the problem, the human and economic cost, the systems and training to improve patient safety, reducing adverse events and errors, but also about a little bit about patient outcomes and experience. And I hope that I can bring a bit more of a patient view into this dialogue as well. Now, as far as problems with patient safety concerned, one of the biggest problems is the assumptions that we make, and whether we make them in our teams, and that's why the team training can make a difference, but also about how we communicate with patients. And I know that Pallavi will say that a lot of the stuff they have to deal with AXA and MPS, and certainly we do in the MDU, is where there have been this misunderstandings. And the worst assumption of all is, I don't know if any of you played Russian roulette. Frank may have done it as a student with cans of beer on rugby tour, but a bit about doctor knows best, or the healthcare worker knows best. And of course, you will be right with roulette at least 5 times out of 6. As far as decision making is concerned, and a lot of the stuff we do is not technical, it's around decision making and communication. We have lots of things to help us in the toolkit. We have evidence-based medicine, ethics, law, decision analysis, health economics, but it doesn't always bring into the fore the patient side. Now, interestingly, David Sackett's original definition of evidence-based medicine, he talked about the integration of best evidence combined with the clinician's experience, but he did go on to say, but taking into account patients' values. And 25 years of the evidence-based medicine policies have somehow forgotten that. And actually, the Centre for Evidence-Based Medicine has its annual conference next week in Oxford. And for the first time, they brought in 2 sessions on patient values and patient involvement in decision-making. So you'll all be aware of the GMC guidance on consent. And for a long time, it's talked about patients and doctors making decisions together. But when you get to when things go wrong, when there are complaints, patients will think, say, but I didn't know this could happen. The GMC currently going through the next iteration of good medical practice up to consultation now, coming out next year, and the Collaborating Centre for Values-Based Practice that I'm the director of is contributing to that. But many of you, I hope, will already be aware of the Montgomery Supreme Court judgment, now 7 years old, and yet I still go to training sessions and teaching sessions, and I say to people in the audience, medical students, doctors, nurses, physios, other healthcare professionals, who's heard of the Montgomery judgment? And it is not universal, but far from it. And often there are only a handful of people in the room who've heard about it. But that absolutely made clear in law that we do have to put together values and what's important to the patient as part of that shared decision-making process. And that's relevant for decision-making about any part of the patient pathway, whether it's for an investigation or it's for an invasive anesthetic procedure or for an invasive surgical procedure. So I want to just share with you one example. A lady called Mrs. Jones had a painful arthritic knee, had been to see her GP 3 or 4 times over about 24 months, and her symptoms had progressed to the stage where her GP thought it was worth referring her to the orthopedic team, because she'd failed with other simple measures. And she saw orthopedics, and this is a story from Oxford, in fact, at the Nuttall Orthopedic Centre. And, you know, good clinician, seen her, did the relevant investigations, and had a discussion with her about it, and then decided that she had significant arthritis and osteoarthritis, and talked to her about a knee replacement. And having told her about the risks and benefits, they agreed that she's going to have a total knee replacement. And she was on her way out of his consultation room, hand on the door partly open, and said, well, thank goodness, Mr. X, at least now I'll be able to do my gardening. And alarm bells were ringing for the surgeon. He said, well, shut the door, come back and sit down, tell me a bit more about this. And it turns out that Mrs. Jones, in her mid-70s, sadly widowed, spent really virtually every day of the year, rain, hail, sunshine, in her garden. That was the love of her life. And she used to enter into the competitions and stuff with the best garden. And he said, well, now we have a problem, because I thought your main problem was pain in the knee, and I can absolutely get rid of the knee pain. But the one thing I cannot guarantee is that you'll be able to garden, because I can't guarantee you'll get 90 degrees of flexion at the knee. And at this point, Mrs. Jones said, well, that's no good to me, I don't want to have it. And they had a further discussion, and she was managed with intermittent non-steroidals and some physiotherapy. And 3 years later, she still hasn't had a knee replacement, and she's happy, and he's happy he didn't do what would have been an unnecessary operation with its attendant risks. So this example of shared decision-making is just, you know, listening to what Mrs. Jones wanted, what was important to her, adding in the best evidence-based options available resulted in an improved outcome for her, a better patient experience. And, you know, that's one knee replacement saved, but there are many more knee, hips, and other unnecessary procedures, each with their own patient safety risk and adverse events around the health service. So I met with this philosopher Bill Fulford about 8 years ago. We set up the Collaborating Centre for Values-Based Practice. And when he first spoke to me about it, I said, I don't know what you're talking about, Bill. We do this all the time. We talk to patients, we discuss what's, and we tell them about the issues, options, and we make a decision, and they and hope that, you know, they'll get a good outcome. And but by the end of the meal, I changed my mind and thought we should meet again. And I just want to talk about how shared decision making has changed my practice. It used to be the case that I'd say to trainees and students, actually there are only 3 types of decisions to make in surgery, whether you're in the clinic, the ward round. One is that there is a particular course of action where the evidence is overwhelmingly in favor of an intervention, where the risks are very low, the benefits are very high, and you can make a recommendation to the patient. Now, the patient could still say, no, thank you. And you might say, well, why do you say that? And maybe I can understand that. And I'm not trying to persuade them to have something, but to understand, as there may have been, as I said at the very beginning, a misunderstanding or an assumption on my part or the part of the patient. So that's about clarification and communication. And the patient can still say no. The other end of the spectrum is where patient is seeking a particular course of action, where all of the evidence is that risks are high, the benefits very low, is not evidence-based, and I say, well, I'm not prepared to offer you this treatment. And my practice used to be that patients would, you could sometimes tell people unhappy, and I'd say, well, I can see you're a bit unhappy with this. Would you like a second opinion from one of my, at that point, I only had 4 colleagues in vascular surgery, one of my 4 colleagues in Oxford. And then about 5 years ago, one of the patients said to me, well, you would say that, wouldn't you? And I said, oh, that's an interesting response. Why do you say that? I said, well, they're all your mates, aren't they? They'll all say the same as you. And I took a deep breath and said, well, I can see why you might say that. You're right. They are my professional colleagues, and I see why you might be worried. And one of them actually is my friend. So that tells you a bit about my relationship with some of my colleagues. No, seriously, we now have, what I've said is, well, actually, there are 250 vascular surgeons in the UK. You can go to any unit, see anybody, I will actively facilitate that. And I've found over the years that if you unsolicited make that offer, when you can see a patient from their body language or what they say to you is difficult for them to accept, only about 1 in 30 or 40 actually take up your offer of a second opinion. The third group of patients is where they might have more than one option, which would be perfectly reasonable. And a good example in vascular surgery of varicose veins, where you can have no treatment, you can have stockings, you can have compressor stockings, you can have injection sclerotherapy, radiofrequency ablation, endovascular laser treatment, or surgery. And I would say, well, these are the risks and benefits. You choose, and whatever you choose, I'll help you and support you and offer you that treatment. Now, I know what you're all thinking. You're thinking, well, we know what the patient's going to say next. And about 3/4 of the time, they do say, well, what would you do, doctor? What I used to do was say, well, just looking at some of the names on the list, I'd say, well, Frank, you can have no treatment. Frank can have injection. John can have sclerotherapy. Someone can have stockings, etc. And that was based on what David Sackett talked about: evidence for the outcomes and clinical experience. And I thought I was doing a good job until I met this guy, Bill, 8 years ago. But the options I was offering them were based on what was important to me. And what I do now is to say to patients, well, interesting you should say, what would I do, doctor? I'm an expert in vascular surgery, but you're the expert in you. If you tell me the sorts of things that are important to you, together we can pick which one of these options might suit you in your particular circumstances the best. So when the patient said to me, what would you do, doctor? Pre-shared decision-making, my answer was based on my values. And I know that some of the Royal Colleges talk about, it's just about more informed consent. Tell them all the possible risks and that will be fine. And I don't think that is. And the Montgomery judgment specifically says, do not bombard the patient with information of long risks and possible adverse outcomes. But you might say, well, what's important to the patient? And then together you can pick a decision that would suit them. So values-based practice and evidence-based practice come together to support shared decision-making. So the evidence-based practice brings the science and the values-based practice brings the person into that equation. The last thing I want to talk about was the 2 feet principle, that all clinical decisions are based both on evidence and on values. And the idea is that the best is where you have both the best available evidence and the values relevant to the individual patients. Now, you might say legitimately, what does this have to do with patient safety? And my assertion is that if you find out what's important to the patient and the patient then becomes part of making that decision choice on the intervention they're going to have, you end up with much better patient concordance with both the treatment plan, post-procedure care, and overall the patient will have a better experience. But here's the crux of it for the legal side of things, is that if you have proper shared decision making, with that better patient concordance, it is true that the safety side will be better, but also the patient shares the outcome. And so when we come to thinking about what I'd say is that in the clinic, my clinic consultations take longer than my colleagues, but I don't spend any time dealing with complaints or seeing lawyers, and that's relatively rare in vascular surgery. So that's my suggestion to you about involving patients more in our decision pathway on what we do with patients, and that way you'll find you spend more time with patients and less time with managers dealing with complaints and the misery of dealing with lawyers. Thank you.
Ashok, thank you very much indeed. There'll be a round of applause that you can't hear, so you'll have to take a virtual round of applause for supplying the fourth bit of the jigsaw today, which is explicitly about communication. Interestingly, all of our speakers have really followed on one from the other, and the themes have been patient safety and quality of outcomes. Above all, communication has been important, and as Annie and Ashok have emphasized, and John as well, and Pallavi, learning is one of the most important aspects of this, and I guess in effect that's what CORESS is trying to promote. So I would thank all of our speakers for their enormous contributions this afternoon, for giving up a Friday afternoon to talk to us. And I'd like to hand back to Lord Ribeiro, if he can access us, to round up the meeting and complete the meeting. And this recording will eventually be available on the CORESS website. So I'd also ask anybody who has colleagues who may be interested to head to the CORESS website at some stage and listen to aspects of this if they wish to. So thank you very much indeed for attending, everybody.
Thank you indeed, Frank, for that and for chairing that session. Really, I have to thank all our speakers. They have given us tremendous insight in their presentations, and I'm really grateful to all of them. I would particularly like, if possible, to suggest that John Machin, when he goes back to his institution, might pass on my best wishes to Tim Briggs, who used to be my registrar doing general surgery before he became an orthopedic surgeon. And Tim has always had a big interest in that area, and I followed his career with great interest. So do pass on my best wishes to him. And similarly, Ashok, who the two of them sort of bookended the program today in a way, but Ashok, a great friend, invited me many years ago to examine at Oxford for the final year students. He was an amazing person, and I would like to thank him again publicly for the support he gave me at that time. So really, it just ends to say that we've had 4 fantastic presentations. Thank you very much, all of you, for staying to listen. I hope you've learned something and will remember the work that CORESS does. And if I can put in a plug for CORESS, it is important that if we are going to prevent patients coming to harm, that we feel confident and safe in ourselves to report any errors that we may have. That is really the thing. If you can put your experiences out in the open, there will always be somebody out there who's done something very similar and will be able to find a way out for you. So please do not keep errors and mistakes to yourself. Use the medium of CORESS as a way of explaining what happened and getting help to see you through. So I'll end by thanking all the members of CORESS who put this program together today, all our speakers, and I would like to thank all of you for giving up your Friday afternoon and coming to this symposium. I thoroughly enjoyed it, and I hope you have too. All the very best, a safe journey. It's going to be a hot weekend, plenty of water, have fun. Thank you. Bye, everyone.
Thank you.
Thank you very much.
Pleasure. Bye.